Most commonly along the mesenteric side of the mesenteric tinea. The most common known cancerous pathology of the colon. Colon diverticular are false because it only contains mucosal and muscular mucosal layers. And the formation is still unclear. Structural abnormalities of the colon wall, disordered motility, and fiber deficiencies, higher interluminal pressures, chronic constipation, especially on the sigmoid colon. The symptoms usually it's a lower left quadrant abdominal pain and systemic wellness, usually fever. It's most commonly on the left side of the colon, usually in the Western society. The right colon, it's only 1 to 5% in the Western population. It's most common in the Asian population. Usually it's confused with appendicitis, and it's a true diverticula, usually with a congenital nature. It happens in younger patients, and it has a benign course. The transverse colon only 6%, usually asymptomatic patients, and the patients usually are 15 to 20 years younger than the patients with the right colon diverticulitis. Rectal diverticulitis only in 0.08% of the patients and needs a true diverticular. So imaging, we use the CT scan. CT with IV contrast is the gold standard with 98% sensitivity and 99% specificity. In complicated disease, we can see abscess, localized or free intra-abdominal gas, visualization, or evidence of obstruction. It confirms the diagnosis and predicts the failure of none. So, what is a complicated diverticular disease? It's diverticulitis associated with localized or generalized perforation, localized or distant abscess, fistula, stricture, or obstruction. Here's the Hinton classification system, the first one and the modified one. I'm not going to talk about it because you're used to it. The Ambrosetti classification, it divides in moderate diverticulitis and severe diverticulitis according to CT findings. The classification for the World Society of Emergency Surgery, it divides in grade 1 when you have a presence of pericolic air bubbles and minimal effusion without abscess. Grade 1B, the abscess is smaller than 4 centimeters. Grade 2A, bigger than 4 centimeters and pelvic abscess. Grade 2B, presence of free intra-abdominal air over 5 centimeters away from the inflamed area. Grade 3, presence of diffused free liquid without free intra-abdominal air. And grade 4, presence of diffused free fluid with free intra-abdominal air. This is a small, just a picture of the Hinton stage for you to see. Stage 1 with localized pericolic abscess, stage 2 large mesenteric abscess, stage 3 free perforation, and stage 4 fecal peritonitis. From stage 2 to stage 4, we classify it as complicated diverticulitis. There are tons of articles talking about complicated diverticulitis, and this is just a few of the articles that I used to do this presentation. So, now I'm going to talk about management of the abscess. Abscess, you're going to treat with antibiotics. If the abscess is more than 4 centimeters, it is probably going to solve with antibiotics. If it's bigger than 5 centimeters, you can try image-guided percutaneous drainage. The IV antibiotics, usually with a broad spectrum, fluids, pain management, and bowel rest. The goals are the resolution of the symptoms and normalization of the inflammatory parameters. Although there is a high risk of recurrent disease, especially in patients with pelvic abscess. This is just to exemplify what to do. So if there's no abscess, antibiotics, success, you can release the patient. If it doesn't work, surgery. If the abscess is more than 3 to 5 centimeters, antibiotics. If it fails, surgery. And if it's bigger than 5, you drain. If it doesn't work, surgery. The management of the hinging tree is when you have perforation, presence of fecal interpolated peritonitis, extent of contamination and hemodynamic status and associated comorbidities. That's what you're going to pay attention on the patient to decide what you're going to do. The operative management is going to depend on the patient age, comorbidities, nutritional state, severity of the disease, surgeon's preference and experience, no video, laparoscopic or open surgery. The fundamental is the resection of the diseased bowel to healthy proximal colon and rectal margins. We must always remember about patients in long-term use of steroids, because it has a higher risk of anastomotic leak and frailty patients and malnutrition. The management with the laparoscopic lavage for the hinging tree, the goal is don't mobilize the colon to identify the perforation. You're going to use 3 to 20 liters of saline. You drain either close to the sigmoid to identify fecal leak or into the pelvis. To identify the clinical failure, you're going to see a lack of clinical improvement, worsening sepsis, development of peritonitis, and requirement for reintervention. But the preservation of the diseased bowel is associated with 3 times greater risk of persistent peritonitis, intra-abdominal abscess, and the need for emergency surgery compared to resection, especially in elderly patients. This is a few trials that compared laparoscopic approach, which is lavage, and surgery. The latest trial is from 2010. They figure out that laparoscopic assessment to the whole abdomen was the idea, and they did identify the site of perforation. But this trial had to be terminated early because it was having more an increased rate of perioperative morbidity and mortality and need for surgical reintervention compared to the resection groups. This candidate from 2020, they put 2 drains, it showed that it did not reduce post-operative complication, and the patients with laparoscopic, they had lower stomach prevalence. The Delilah from 2018, they used saline washout, placement of a drain, avoid identification of perforation, and they figured out that it was better than the resection. The Lolo trial from 2021, it's a branch from the ladies trial. In the end, they think that the less operations and lower stomach rates with laparoscopic patients, and they didn't find any differences in morbidity or mortality. With this table, there's just a small comparison with the ladies, Lola, Scandiv, and Delilah, with the number of patients, the morbidity, the mortality, and as you can see, the laparoscopic patients and the patients who had surgery are almost the same number. The difference is the Delilah patients had open Hartmann's procedure. The others had sigmoidectomy. And morbidity was higher for laparoscopic lavage in all of them, and mortality was higher on the open Hartmann's procedure on the Delilah. The management of hinging 4, when you have a free perforation and feculent peritonitis, it equals surgery. Resect inflamed and perforated bowel segment. But what to do? Hartmann or primary anastomosis? My colleague is going to discuss it. So just talk fast about it because it's the next topic. To think about fistula, usually it's colovesical fistula. You don't need to close the bladder, and you can use methylene blue test to see the tract. Urgent or emergency surgery, whenever you have signs of diffuse and or fluid perforation, suspicion of malignancy, and inadequate response to none after 72 hours, you can consider laparoscopic surgery for stable patients. And always start a resuscitation with 30 milliliters keyless fluid bolus and vasopressors if there's no response. Damage control surgery, something that we've been talking about in inflammatory disease, usually in unstable patients with generalized peritonitis, non-responsive to fluids, and needing of vasopressors. Laparoscopic elective sigmoid resection for patients with recurrent, complicated, or persistent painful diverticulitis. And they all agree that there's a need for routine colonoscopy after 6 weeks. For you to memorize and summarize everything that was said, you have to think about hemodynamic stability of the patient and if they respond or not to fluids. That's how you're going to decide which surgery you're going to do. This is just the breadth of patients with abscess and purulent or fecal peritonitis. The size of abscess, again, the hemodynamic stability of the patient is what's going to take you to decide which surgery. So I'm from Rio.